Today, a topic of our discussion is how to approach a patient of unconsciousness. So, uh, so first, we have to know what is unconsciousness and how a patient of unconsciousness presents, and what are the underlying causes, and how to react if a patient is coming to us in an ER. So, unconsciousness is a state which occurs when the ability to maintain an awareness of self as well as environment is lost. This patient is unaware of either themselves as well as to the environment, and it involves a complete or near complete lack of responsiveness to people and other environmental stimuli. So there are lots of causes of unconsciousness, and there are multiple classification of unconsciousness, which includes either acute or chronic, and metabolic, traumatic, vascular, infectious causes, and so on. So metabolic causes includes drug overdoses like Panadol or paracetamol abuses, Ascard abuse, any club drugs like acetaminophen abuse, and a patient of diabetic, known case of diabetes, which may become unconscious if they have severe hypoglycemia, ketoacidosis, hyperosmolar non-ketotic coma, uremic encephalopathy, hepatic encephalopathy, and severe hepatic failures, certain causes of inborn error of metabolisms, further on respiratory failure, usually with a type 2 respiratory failure. If they become prolonged and due to sudden carbon dioxide accumulation, they may go to the severe unconscious in the comatose state. Severe hypothyroidism, where patient with a severe unconsciousness, hypothermia, bradycardia, and also the patient of the hypothermia due to some other causes may go to unconscious state. Trauma like cerebral contusions, diffuse axonal injuries, other include extradural and subdural hematomas. Vascular disease, usually subarachnoid hemorrhages, brainstem infarction or hemorrhages, and intracerebral hemorrhages. A patient of usually ischemic stroke of cerebral origin, usually they don't present with the unconscious. They usually present with either monoplegia, hemiplegia, or difficulty in speaking or degglutinations. And other causes include meningitis, which are infectious causes, encephalitis, cerebral abscess, systemic sepsis, as well as cerebral malaria, which is very common in this part of the world, and brain tumors, epilepsies, and functional patients. So these are the causes of unconsciousness broadly, which includes acute as well as chronic causes of unconsciousness. So how can we differentiate these patients of unconsciousness for simplicity and to reach the diagnosis in a systemic way? So we categorize these patients as those patients having focal neurological signs, without focal neurological signs, as well as meningitic syndrome. So those patients who have no focal neurological signs means any localizations, and which is usually categorized first by examination, which may reach to the diagnosis, and patient may present with either monoplegia, hemiplegia, or dysphasia, that is patient having global aphasia. So all these are the localizations, and CT scan and cellular contents of the CSF are normal, right? In which no any focal neurological signs you get. But if a patient is coming to you with the focal neurological features, which I already told, with or without changes in CSF, and CT scan and MRI are all abnormal. Say for suppose if a patient is coming to you with a case of the hemiplegia and with the unconsciousness state. You examine this patient as patient having a loss of pupillary reflexes, corneal reflexes, Tall's eye movements are absent, and neck rigidity is there. So you may get an impression a patient might have developed brainstem infarction or hemorrhages. In these states, CSF usually gives a clue in case of the subarachnoid hemorrhages, and in case of brainstem hemorrhage infarction, MRI usually gives you the clue where brainstem infarction or hemorrhages will be localized. So if a patient is coming to you with the focal neurological signs, you may get MRI changes, CT scan changes with or without CSF changes. Another classification is patient is having meningitic syndrome with an excess of WBCs in the CSF, usually without focal signs. And what are the meningitic syndrome, which includes neck rigidity, chronic sign, and Brunzelke signs, where patient is having a fever or severe headache for the last few days and patient become unconscious. And CT scan or MRI shows no any mass lesion. So diseases without focal neurological signs or localizing signs in which CSF and CT scan are usually normal, which includes usual alcohol intoxications, sedatives or anxiolytic abuses, opioids, metabolic disturbances like anoxia, hyponatremia, hypernatremia, hypercalcemia, diabetic ketoacidosis, hypoglycemia, uremia, and Addisonian crisis. Severe systemic infections like septicemia, typhoid fever, if lasts for the few days, then present with unconsciousness as well. Malaria, shock from any causes that could be because of the septicemic shock, anaphylactic shock, post-seizure states, and as well as hypertensive encephalopathy, severe hyperthermia or hyperthemia. These are the causes where you won't find any focal neurological deficit. But if you find any focal neural deficit, then there are certain differential diagnoses that could be CNS hemorrhages or infarctions, brain abscess, subdural empyema, brain tumor, trauma like epidural, subdural hemorrhage, and history will usually guide you to the diagnosis. Metabolic states with pre-existing focal damages, other include cortical vein thrombosis, herpes encephalitis, septic emboli, due to bacterial endocarditis, and cerebral vasculitis. Meningitic syndromes usually, because as name suggests, meningitic syndrome means patient is having meningeal irritations. And signs of meningeal irritations are, as I already told, neck rigidity, chronic signs, and Brunzelke signs. And in these patients, fever usually occur in case of meningitis, like in bacterial, viral encephalitis, or tuberculous meningitis. But in case where subarachnoid hemorrhages occur, usually patients don't present with fever, but they have a history of sudden severe class like thunder headache and followed by severe unconsciousness. So this is the called meningeal irritation with or without fever and with an excess of WBCs or RBCs in CSF. Usually without focal or lateralizing cerebral or brainstem signs, and CT or MRI shows no mass lesion. What are the causes of it? Like subarachnoid hemorrhages from ruptured aneurysm, AV malformations, bacterial meningitis, tuberculous meningitis, viral encephalitis, rarely fat embolism, cholecyembolism, carcinomatous and lymphomatous meningitis, which are very rare conditions. So how to approach first? History is very important to reach the diagnosis. And what history would you like to ask in these patients or from the attendants? First, circumstances of rapidity, because a sudden onset of neurological deficit or sudden onset of unconscious will usually lead to rapid action of in ER. So, what are the causes of sudden onset patient of unconsciousness? That could be subarachnoid hemorrhages, severe hypoglycemia, or any intoxications, or any vascular or traumatic lesion like subdural or extradural hematomas. So circumstances rapidly with neurological symptoms develop. First, you would like to ask any antecedent symptoms like confusion, weakness, headache, fever, seizures, dizziness, diplopia, or vomiting. Diplopia, vomiting, headache, seizures, which usually indicates patient having subarachnoid hemorrhage. And if a patient is having fever, then meningitis or encephalitis. Use of any medications, drugs, alcohols, or prior any history of abuse, any prior comorbid like liver disease, kidney disease, heart, or other disease. Because in case of chronic liver disease, patient may go through hepatic encephalopathy or hepatic coma. In case of Any heart disease, patient of heart failure, usually precipitated by fever, and they develop unconsciousness as well. Somebody asked, subarachnoid hemorrhages changes can be seen in CT. Yes, of course. You can see hypertense areas in the sylvian fissures as well as in the ventricular areas. So these are the few clues which leads to diagnosis of the subarachnoid hemorrhages, where CT scan shows fluid in the or hyperdense area in the sylvian fissures as well as in the ventricles. Now, attention is then directed towards assessment of the patient, severity of the condition, and diagnostic evaluation. But please don't waste time in unnecessary investigations or excessive investigations, because your first aim would be to save the patient and to reach the diagnosis and to start the treatment at the earliest. So, assessment of the patient, severity, and diagnostic evaluation, all possible information from relevant any paramedics, ambulance personnel, or somebody who was taking care of the patients. So what things you would like to examine if a patient is coming to your ER after history? First, you have to ensure patient is having ABCs maintained, like airway, breathing, and circulation, IV access, and blood should be withdrawn for routine investigations. Routine investigations like CBC, urea electrolytes, LFTs, PT-INR, blood cultures, glucose, and other biochemical parameters. And if your working environment and if conditions suggest the patient might have taken some drugs, so toxicological screening of urine as well as blood, if available in your setup, you may go for it. So clues, what clue you would like to see in these patients? First, from the clothing or from handbag. You might get some smell in case of some drugs. Handbag may carry some packages or catch cover of the drugs patient might have using, or bottles of any drug. Careful examination for trauma, which require complete exposure from the back as well as front, and in needle marks, tattooing marks. If head trauma is suspected, then examination must await adequate stabilization of the neck. Because if you keep on moving the neck, then patient may have you may have damaged the neck or spines of the patient. GCS severity of coma scale is essential. Patient what in what category patient is fulfilling criteria, and following this particular attention should be paid to the brainstem and motor examination. So, what examination parameters you would like to see first? Of course, you would like to see for blood pressure, pulse, temperature, respiratory rate, oxygen saturation. So, pulse, bradycardia in case of any brain tumors, opiates, raised ICP, uh, myxedema in case of viral infections where raised ICP is there. Tachycardia will lead to diagnosis of sepsis, hyperthermia, hyperthyroidism, and uremia. Blood pressure, usually high blood pressure in case of hypertensive encephalopathy, where blood pressure, usually systolic blood pressure is more than 180 and diastolic more than 110. If you are seeing a patient having low blood pressure, less than 90, less than 60, despite adequate fluid resuscitation, then that could be because of the Addisonian crisis, alcohol intoxication, barbiturates, myocardial infarction like inferior wall MI usually presents with hypovolemia and hypotensive shock, as well as severe sepsis, where distribution shock is there and systemic vasodilation will lead to blood pressure, low blood pressure. So you have to consider these things like blood pressure, pulse, temperature, respiratory rate, and oxygen saturation as well. So high temperature in case of sepsis, meningitis, encephalitis, heat stroke, which is very common nowadays, anticholinergic drugs, intoxication, which usually those people who are working in the farms and usually in the farms. And hypothermia in case of alcohol, barbiturates, sedatives, intoxication, very high, severe hypoglycemia, and of course, in myocardial infarction, where usually presents with cold peripheries and peripheral circulatory failures. Respiratory tachypnea in case of acidosis, severe pneumonia, or respiratory failure of any etiologies, and aberrant respiratory pattern in case of brainstem disorders. More precisely, medulla oblongata where respiratory center usually present. So, skin condition of the skin will usually guide you to some extent. If you look carefully, like skin in case of injuries, bruises, traumatic, which gives you clues there is some sort of traumatic insult is there. Dry skin in case of severe hypovolemia, diabetic ketoacidosis, atropine ingestions, moist skin in case of hypoglycemic coma, cherry red skin usually in the tongue, where carbon dioxide poisoning, like those who are living in very close areas and having generators all the time. Needle marks for drug addictions, rashes in case of severe sepsis, meningitis, endocarditis, where rashes you will find in all over the body. Order, usually it is very difficult to appreciate the order because you won't go beyond certain limits to the patient. But some breaths are usually very peculiar to some conditions where acetone fruity breath in case of diabetic ketoacidosis, fetal hepaticus in case of hepatic coma, and these two smells are very common. And if somebody appreciates it, then you won't forget in your life, because fetal hepaticus, it smells like a dead mouse. So if you have appreciate this smell in your life, then you won't forget. And there's acetone that is like a pleasant fruity odor, and uriniferous odor in case of uremic coma, alcoholic odor in alcoholic intoxication. So these are a few peculiar breaths of certain conditions which you usually appreciate in your practices in ERs. So level of arousal is really very important to see whether patient is functional or truly unconscious, or at what level of GCS score patient is categorizes. So tickling the nostril with a cotton wisp is a moderate stimulus to arousal. Pressure on the knuckles or bony prominence like sternum, pinprick stimulations are usually a form of noxious stimuli. Pinching skin causes unsightly ecchymosis and is generally not necessary, but may be used for eliciting abduction withdrawal movement in case of GCS criteria. We usually perform pressure over the knuckles or bony prominences like sternum, or usually sternum we usually do in case of the level of arousal. But here one thing you keep on learning in these scenarios, because whenever you are applying a pressure on the sternum, then make sure you won't harm this patient, because this is a very painful condition, and attendant might have some sort of reactions in these scenarios. So GCS scale, usually Glasgow Coma Scale, into categorizations of level of arousals, and it scores maximum of 5 and minimum of 3. And it includes best motor response, which includes 6 scores, verbal response 5, and I for 4. Best motor response 6 if somebody is obeys commands, localizing painful stimulus of 5, flexion to painful stimulus is 4, abnormal flexion in 3, and extensor response 2, and if null, then it is 1 score. I'm going very fast because in previous lecture, in the state of coma, we discussed in detail of GCS scores. So verbal response, if well oriented, that is 5, confused but conscious, this is 4, inappropriate word is 3, incomprehensive sounds, there is a difference between inappropriate word and incomprehensive sounds. Inappropriate word, patient usually doesn't respond to exact stimuli or exact word, this is inappropriate. And if you are unable to appreciate the words, means mumbling, then this is called incomprehensive sounds. And if you are unable to listen voice, then this is verbal response 1. Eye opening if it's spontaneous, then this is 4. Eye opening to speech, if you are calling somebody and he or she responds by opening the eyes, then 3. To some pain like in the sternum or under other body prominences, then 2. And if no any eye response, then this is 1. Now, posture has certain importance in case of localizing whether the patient is having cerebral lesions or in the brainstem lesions. So there are certain posture like decorticate rigidity and decerebrate. Decorticate means flexion of elbow and wrist, and supination of arm, and it leads to usually in case of midbrain lesions. Like elbows are flexed and wrists are flexed as well, and there is supination of the arm. So this leads to midbrain lesion. Decerebrate rigidity means extension of elbows and wrists with pronation. I'll show you in the next slide, and it usually leads to damage to the motor tracts. Right, you can see here decorticate rigidity and decerebrate rigidity. In decorticate rigidity, where lesion is usually in the midbrain, and decerebrate where usually lesion in the motor tracts in midbrain or caudal diencephalon. So cortical lesion. Cortical lesion usually decerebrate, and brainstem lesion usually decorticate rigidity. So in decorticate, elbows are usually flexed, you can see, and wrists are also flexed, and limbs are internally rotated and plantar flex. Whereas if you can see, in case of decerebrate, patient is usually pronated, and elbows are extended, wrists are also extended, and plantar are flexed in both conditions. But major difference in decorticate, elbows and wrists are flexed, and supination of the arm. Whereas in case of decerebrate rigidity, elbows are extended and arms are pronated. Here you can see this is pronation, and this is supination of arm. So brainstem reflexes are usually required for examination, and this includes pupillary reflexes, ocular reflexes, corneal reflexes, and respiratory pattern. As a rule, coma due to bilateral hemisphere disease usually preserves these brainstem activities. Like pupillary reflexes are intact, and in these cases where we have a confusion whether this is hemispheric lesion or brainstem lesion. So we usually keep on check these reflexes, because if somebody is having only bilateral hemisphere lesion, then these reflexes like pupillary, ocular, corneal, and respiratory reflexes are intact. Pupils, what we usually see: size, inequality, reaction to bright light. An important general rule is usually most metabolic encephalopathies, like due to drugs or diabetic or other lesions that is metabolic causes. They usually gives you small pupils, but with light reflexes are intact. Atropine and cerebral anoxia tends to dilate the pupil, because atropine is parasympatholytic drug, and opiates, which is parasympathomimetic, which usually causes constrict the pupils. So reactive and round pupil of mid-size essentially exclude any midbrain, because if somebody is having brainstem lesion, then his or her pupils are non-reactive and unequal size. Whereas if somebody is having reactive and round pupil size, then it usually excludes the midbrain or brainstem damages. Structural lesions are usually associated with pupillary asymmetry, which include midbrain lesions where round, regular, medium-sized pupils, but they do not react to light. This is very important. If somebody is having midbrain lesions, then all the reflexive pupillary parameters are normal, except they don't react to light. Whereas if somebody is having cranial nerve 3, then ipsilateral fixed dilated pupils. If pontine lesion, then bilaterally small or constricted pupil, and these are non-reactive. Lateral medial lesion, ipsilateral Horner syndrome, and Horner syndrome is characterized as usually patient is having sunken eyes, partial tosses, and socket of the eyeballs are inward placed. And usually patient experiences no usually absence of sweat on the affected side, and this usually due to because of the sympathetic drug involvement. Occluded carotid artery usually causes pupil on that side is often small. So these are the pupillary changes usually which carries, in which midbrain lesion usually non-reactive light, cranial nerve lesions, ipsilateral fixed but dilated pupil, and pontine having small pinpoint pupils. Motor function, particular attention should be directed toward asymmetry of tone or movement. That is called localization. And plantar responses are usually upgoing or extensors, but asymmetry is also important, right? because some patient you don't find in every patient there's extensive responses, but you may find asymmetry like no response, or we called mute. Tendon reflexes are usually less useful because most of the patient of motor reflexes, tendon reflexes are exaggerated. But if some patient is coming to you within 24 hours, then due to spinal shock, reflexes are normal or even reduced. So motor response to painful stimuli should be assessed carefully as a part of GCS. So motor function includes symmetry of the tone, power, reflexes, as well as coordination of the movement. Painful stimuli and patient usually localize or exhibit a variety of responses, and asymmetry is again important to localize the lesion where a lesion in case of the brains. Meningeal irritation signs includes neck rigidity, Kernig sign, and Brudzinski sign. If you people want to ask any question, you may drop a message in your chat box. So here you can see Brudzinski sign and Kernig sign as well. Now, what diagnostic test is required? Previously, we ordered some routine investigations, now diagnostic tests. In case of patient is having like renal impairment, hepatic impairment, then you order ABGs or respiratory involvement. Then you order ABGs, electrolytes, glucose, urocreatinine, CBC, liver function test, and urinalysis. ABGs for metabolic acidosis, like in case of diabetic ketoacidosis, renal impairment, like chronic kidney diseases, in case of any drug intoxication where patient is having acidosis, serum electrolytes again for hyponatremia in case of hepatic failures, and hyperkalemia for renal impairment, glucose again, hypoglycemia or hyperglycemia, creatinine to see the function of the kidneys, CBC for any infective causes as well as thrombocytopenia in case of severe sepsis, LFTs and urine analysis again for liver and renal status respectively. So drug levels ordered if it's the conditions or patient suggestive of drug intoxication, and toxicological screening for blood and urine if suspected as well. So imaging, if you are suspecting a localizing brain lesion, that could be because of the subdural hematoma, extradural hematoma, subarachnoid hemorrhages, brainstem lesions, or brain infections. Then you order first CT scan. And here, very important thing is don't order MRI in emergencies because CT scan is cost effective and usually very rapid diagnostic, where MRI takes some time and is not usually facility available everywhere. So if you're suspecting any lesion, then first order CT scan to rule out any important hemorrhages or other lesions like raised features of raised ICP or ventricular enhancement or so brain MRI can be useful if CT scan is non-diagnostic and there's suspicion of ischemic or parenchymal lesion, especially of the posterior fossa, right? But it should be done after CT scan. Procedures again, LP, fundus examination, and CSF stand for routine investigations, gram stain, and special investigations for herpes simplex PCR, electroencephalography for seizures, and non-convulsive status epilepticus, which is very common cause of unexplained encephalopathy in critically ill patients. Features for raised ICP, usually we don't have apparatus to measure ICP, but there are certain features of raised ICP like morning headaches and planters, upgoing planters, and patient having decreased conscious level. Usually ICP normal ventricular pressure is less than 15, and if somebody is having raised ICP, then our target is usually to keep the pressure less than 20, and there are certain drugs to lowering this. First is first parameter is elevation of the head and drain CSF by ventriculostomy, but this is very rare procedure. We usually go for mannitols and glucocorticosteroids like osmotherapy with a mannitol or hypertonic saline if having renal impairment, glucocorticoids, hyperventilation with non-rebreathing bags, and pressor therapy like dopamine, norepinephrine, and other if a patient is having refractory elevated ICP despite these measures, then decompressive craniotomy, high dose barbiturated therapy, and hypothermia to 33 degrees centigrade. So this will ease out the ICP pressures. Now, prognosis in general, usually unconsciousness state underlying etiology usually leads to what kind of prognosis is having. So, if a patient is having large extent of damage and patient present with a comparable later time, so it having a prognosis, a very poor prognosis, and unconsciousness or coma due to antidepressant drugs or depressant drugs carries excellent prognosis. Where metabolic causes, apart from anoxia, better prognosis, structural lesions and head injuries having poorer prognosis. Now, prognosis usually, as I told, depends on underlying cause, comorbids, and age of the patient. And if somebody, this is a chart showing how to proceed with a patient of unconsciousness. So first, assess what underlying condition is, then treat airway, breathing, and circulation, evaluation for brainstem reflexes, any localizations, motor response, and breathing pattern. Because if breathing pattern is diminished, then that may be because of the midbrain lesions or medulla oblongata lesions. Immediate sign for glucose, electrolytes, ABGs, CBCs, LFTs, endocrinology tests like go for Addison's workup and thyroid. Toxicology screening and cultures. PAN culture means culture for blood culture, CSF culture, urine cultures means where the lesion you are suspecting. And if etiology not immediately identifiable, then emergent head CT scan. Look, I told you CT scan is emergency investigations. Don't go and don't order MRI in emergencies because this may usually compromise your patients. So if herniation syndrome or raised ICU features and hyperventilation, which I already told, via rebreathing back to PCO to 35 to 30, mannitol 0.5 to 1 gram per kg. Usually we give 50% in the first hour and then 8 hourly with the 25%. Thiopental and neurosurgical concentration for craniotomy. If hypoglycemia is there and less than 60 milligram per deciliter, go for thiamine because usually a patient are having intoxication or patient having low nutrition status. Then first replace thiamine before going to glucose because if you give them glucose without replacing thiamine, then neurological condition usually worsens. So this is a message for you people. First go thiamine and then glucose 50 ml or 50% dextrose 25 gram. If seizures are suspected, then give lorazepam 1 to 2 mg IV. If suspected opioid overdose, then go for naloxone, that is opioid antagonist. These drugs are usually available in ERs. And if benzodiazepine overdose is suspected, then flumezolone. And if drug intoxication is suspected, gastric lavage with activated charcoal. So if a patient having hypoglycemia, first replace with the thiamine and then glucose. If suspected any seizures, go for lorazepam. If suspected opioid, then naloxones. These are antagonizing for these drugs. If benzodiazepine overdose, then go for flumezolone. And acute intoxication of no any identifiable etiology, then go for gastric lavage and activated charcoal. If persistent etiology unclear, then consider MRI, EEG, and other interventional procedure like CSF analysis, LP. So neurological support, what support you would like to offer these patients? First, protect the airway if necessary by endotracheal intubation. Provide respiratory support to correct for hypoxemia, hypercapnia. So for these, you give the oxygens or even BiPAPs and endotracheal intubations. Circulatory problem with neurogenic pulmonary edema in cerebral hemorrhages, autonomic disturbance in Guillain-Barré syndrome and spinal shock, acute brain injury with control of ICPs, and manage status epilepticus with anti-epileptic drugs like levetiracetam, phenytoin, and benzodiazepines. So aim of management acute brain injury is optimize cerebral oxygen delivery, by maintaining arterial oxygen content and cerebral perfusion pressure. So this was all about how to approach with the patient of unconsciousness. And you may take break for 5 to 10 minutes, and then we'll again join with stress and its management. So if you have any query, any question regarding this unconsciousness topic, you